Good evening. I am myself Dr. Nipun Gumbar, currently working as an associate consultant in Manipal Hospital, Dwarka. So, today I will be telling you in brief regarding the ultrasound of prostate, like how we do a transabdominal and a transrectal ultrasound of prostate, and I will discuss some of the common pathologies of the prostate. Okay, so this is the bladder, and just below the bladder sits the prostate gland, and on the either side of the prostate gland lies the seminal vesicle. So let's study about the ultrasound of the prostate. So uh, if we dissect the prostate, it reveals the zonal anatomy in which the prostate is divided into 4 glandular zones surrounding the prostatic urethra. Okay, first one is the peripheral zone, second is the transition zone, third is the central zone, and fourth one is the anterior fibromuscular zone. Okay, so you have to remember, this is the transition zone, this is the central zone, this is the fibromuscular stroma, and this black one is the peripheral zone. So again, to revise, this is the transition zone, central zone, peripheral zone, and fibromuscular stroma, and this is the, as we all know, this is the urethra. So the peripheral zone, which is the largest of the glandular zone. So the peripheral zone, which is the largest of the glandular zone, arises from the urogenital sinus, and in a young man before the onset of BPH, it contains approximately 70% of the prostatic glandular tissue, and it is a site for about 70% of prostate cancer. So peripheral zone is the site of prostate cancer. It is separated from the transition zone and central zone by the surgical capsule. And this surgical capsule is a hypoechoic line that is rendered hyperechoic by the frequent accumulation of corpora amylicia or calcifications along it. The young transition zone contains about 5% of the prostatic glandular tissue. It is visible as 2 small glandular areas, and this transition zone enlarges in the BPH. So just to summarize, prostatic cancer, the site is the peripheral zone, and in BPH, the site is the transition zone. The central zone, along with the seminal vesicles, arises from the Wolffian ducts. Okay, so again, this is the urethra. Just beside the urethra is the transition zone. This is the central zone. This is the ejaculatory ducts. This is the anterior fibromuscular zone, and this green one is the peripheral zone. So transabdominal technique. So firstly, you should always stand on the right side of the patient, and regarding the machine, it depends on vendor to vendor, but you should stand on the right side of the patient, holding the probe with your right hand, and through the filled bladder, the bladder should be filled. The prostate and seminal vesicles are easily seen by angling the transducer approximately 10 to 20 degree inferior and posterior to the pubic symphysis. So place your probe approximately 10 to 20 degree inferior and posterior to the pubic symphysis, and you will be able to visualize the prostate and the seminal vesicles, and the urinary bladder should be moderately filled, like it should be around 150 to 200 cc for the better visualization of the prostate. The seminal vesicles are seen through the bladder behind the trigone of the bladder. The prostate is located inferior to the urinary bladder. The patient lies supine. The patient should have a half full of bladder, 500 ml of water, 1 hour before the scan if possible. The probe is angled 30 degree caudal using the bladder as a window. Slight compression to ensure that the inferior portion of the prostate is not obscured by the shadow artifact from the base of the bladder. So make little bit, you have to press in the pelvis so that there is no nearby shadow which is obscuring the base of the prostate. So first, to get a longitudinal view or the sagittal view, place the probe in the 90-degree position with the marker of the probe towards the patient head. So you will get a sagittal or the longitudinal view of the prostate, and angle the probe caudally, little bit caudally, and in the midline in the pelvis. This is the urinary bladder, and you will see that there is a prostate just behind the urinary bladder. This is the transverse view. So this one is the longitudinal or the sagittal view, and in the transverse view, turn the probe 90 degree and angle caudally to get the transverse view, and you will see the well transverse view of the prostate. And the marker of the probe should be at the right side of the patient. So this is another image showing the transverse view. The normal prostate is oval with a large transverse axis. This is the longitudinal view. The prostate may have a small V-shaped incision on the cranial side. Like here it can have a V-shaped incision so sometimes the prostate may have a small V-shaped incision on the cranial side where the urethra enters the prostate, and after transurethral resection this side can become much larger. So this is the V-shaped side. The transabdominal ultrasound can access the volume of the prostate, but it is not reliable to diagnose the carcinoma. So to diagnose the carcinoma, we do a transrectal ultrasound. So how do we calculate the volume of the prostate? We take the 3 dimensions of the prostate, AP view, transverse, and this longitudinal view, and we calculate the volume of the prostate. And the normal volume is 25 cc. Next is the transrectal ultrasound of prostate. The visualization of the prostate using the truss technique has improved the diagnostic ability of the sonologist. It plays an important role in most of the prostatic diseases. It is necessary for all prostatic biopsies. If the PSA is elevated or increasing rapidly, or there is an abnormal prostate examination, then the transrectal ultrasound and prostate biopsy may be indicated to obtain the tissue to make the diagnosis of prostate cancer. So how do we do a transrectal ultrasound of the prostate? It is ideal to have a small amount of urine in the bladder. Okay, then ask the patient to try and relax and bear down to open the sphincter as the transducer is inserted slowly. Ensure the transducer has a latex-free dedicated probe cover with a plenty of gel, that is lignocaine gel, on it. The highest frequency sector probe, that is 7 to 12 MHz, should be used. The scanning begins in the axial plane. The seminal vesicles are examined initially. As the probe is angled caudally, the base of the prostate is seen. Once the prostate is examined in its entirety in this plane, the probe is turned 90 degrees in the sagittal plane. The probe is angled from one side across to the another, and the volume is taken by measuring the height and length in sagittal plane and width in the axial plane. Look for any changes in the contour and echogenicity in each zone. So I will just summarize you the transrectal ultrasound of the prostate. Firstly, take written and informed consent with the patient that transrectal ultrasound has to be done. Secondly, ask the patient to empty the bladder. Only small amount of urine can be still left in the bladder. Then ask the patient to relax and tuck his knees towards the chest so that the sphincter get relaxed and you can easily insert the probe in the anus. Now cover the probe with the dedicated probe cover and put lots of lignocaine gel. Now put some lignocaine gel near the anal opening and with a gentle pressure insert the transducer in the anal canal. Now scanning begins initially in the axial plane. Once you have seen the axial plane, turn the probe 90 degrees so that you can scan in the sagittal plane and see for any altered echogenicity or any abnormal vascularity or any focal lesion on this, and then see the seminal vesicles as well as the ejaculatory duct. So this is the position for the transrectal ultrasound. Ask the patient to tuck his knees toward the chest, cover the upper portion of the patient and gently insert the transducer. So this is the normal images. Here you can see this is the axial view and this is the sagittal view, and you can calculate the volume of the prostate. So now let's discuss in brief some of the pathologies of the prostate. Most commonly is the BPH, benign prostatic hyperplasia, prostatic carcinoma, prostatitis, prostatic cyst, and last seminal vesicle or stones in the seminal vesicle, prostate or ejaculatory ducts. So the first one is I would be just sharing you with some of the, just to give you the insight about the pathologies. Prostatitis, on ultrasound you can see that the prostate is enlarged and you will see it appears heterogeneous in ecotexture with increased vascularity on color Doppler, suggestive of prostatitis. Prostatic abscess, it can be a rare complication of prostatitis. Transrectal ultrasound is a reliable imaging method to diagnose it. It usually demonstrates ill-defined hypoechoic areas with enlarged or distorted prostatic gland. There can be inhomogeneous echoes within, and there will be no internal vascularity in prostatic abscess. See, you can see hypoechoic area with no internal vascularity. Prostatic cyst, in the midline you can see there is a simple cyst. These are related to the atrophy of the prostate gland as well as the other known factors such as inflammatory disease, BPH, ejaculatory duct obstruction and cancer. These cysts will have a well-defined wall. There will be no vascularity on color Doppler. Prostatic calcification, it is a very common finding, usually after the age of 50. There can be solitary or as well as cluster. These on ultrasound, these appear as a brightly echogenic foci that may or may not show posterior acoustic shadow. Benign prostatic hypertrophy, it is an extremely common condition in elderly men and it is a major cause of outflow obstruction. Although the term prostatomegaly is often used interchangeably, strictly speaking, prostatomegaly may refer to any cause of prostatic enlargement. So as the patient ages, the chances of BPH increases. This is the normal prostate and the urethra. So when there is a benign prostatic hyperplasia, you can see that there is a urethra is compressed, which results in repeated increased frequency of micturition. So ultrasound has become the standard first line investigation after the urologist finger. Typically there is an increase in the volume of the prostate exceeding 30 cc. The central gland is enlarged and is hypoechoic or of mixed echogenicity. Calcification can be seen both within the hypertrophied gland as well as the pseudocapsule. Post-micturition residual volume is typically increased. The exact causes are unknown, but some of the risk factors are age more than 60, family history, diabetes, heart diseases, lifestyle. So here you can see the prostate is enlarged, measuring approximately 94 cc. Another case in which the enlarged prostate with a median lobe of the prostate projecting into the bladder, and with this result projection, there is a significant retention of urine. Now comes the last part, prostatic cancer. Prostatic cancer ranks as the most common malignant tumor in men, the second most common cause of cancer-related deaths in men, and the most common histological type is the adenocarcinoma. Here you can see there is a irregular nodular lesion in the prostate and compressing the urethra, and this is a case of prostatic cancer. And as told you, prostatic cancer are generally diagnosed on transrectal ultrasound. Here you can see this is the prostate. Okay, there you can see a hypoechoic mass lesion in the peripheral zone of the prostate showing internal vascularity, and this is the example of a carcinoma of the prostate. So transrectal ultrasound is often initially performed in order to detect abnormalities and to guide biopsy, usually following an abnormal PSA or digital rectal examination. Ultrasound is used to direct biopsy of a suspicious hypoechoic regions, usually in the peripheral zone. Because of the high incidence of multifocality, systematic biopsies are recommended. On ultrasound, prostate cancer is usually seen as hypoechoic lesion in the peripheral zone but can be hyperechoic as well as isoechoic. Transrectal ultrasound is the modality of choice for directing brachytherapy seeds into the prostate gland. These are some of the risk factors which are linked to prostate cancer. For example, wrong diet, increased PSA, decreased blood flow, age, too high calcium intake, significant weight gain, unhealthy colon, decreased blood selenium, decreased zinc, abnormal omega-3, insulin resistance, race, family history, increased blood levels of IGF-1, exposure to anabolic steroids, increased height, genetic mutations. So this is an example of prostate carcinoma on truss. You can see a well-defined hypoechoic nodule in the left peripheral zone. Okay, and there is an interruption of normal green band on elastography with a stiff area that corresponds to the nodule. Here you can see there is no green area, that means the stiffness is increased, and on biopsy it confirmed out to be a prostatic carcinoma. Again, there is a hypoechoic lesion in the right side in the mid gland portion. The lesion is hypoechoic and it shows significantly increased vascularity on color Doppler, and on biopsy it came out to be a carcinoma. Okay, so just to summarize again, if you want to see the BPH, that is benign prostatic hyperplasia, transabdominal ultrasound is sufficient. But if you are suspecting carcinoma, like if you have a patient with increased PSA or any abnormal per rectal examination, always do a transrectal ultrasound of the patient, because carcinoma are easily detected on transrectal ultrasound. And still, if you are confused whether it is a carcinoma or not, then you should go for MRI, prostate, multiparametric MRI for further evaluation. So I hope you understand this in the few of the slides. If you have any doubts, please let me know. I am on the Telegram group, as well as you can contact the StudyMEDIC people and they will give me all the queries. Okay, thank you. Have a nice day.